My presentation is necessarily an ode to what I've learned from Professor Mortada. And first, I would like to profusely thank him for removing the myth and saving me from learning the art of macular buckling and realizing that this surgery can be done effectively without knowing the nuances of that. So, I would like to present a couple of cases, and because he has already covered the topic beautifully. So this is a 38-year-old female patient with this decrease of vision in the left eye. And I saw her in, this was in 12th March 1919, and this was the picture. I advised her surgery. I in fact advised her to come back to me after 2 months so that I could document progression and advise surgery. She decided to wait a year, no harm. She came back with 636 vision after a year. And the schisis had progressed with almost a hole forming and a large detachment across the fovea. So I like to combine most of these cases with phacoemulsification because that takes care of the myopia from the point of view of the refractive component. ILM peeling, I used, because the eye was large, I used C3F8. I use only 10%, or I use SF6 10%, or I use just air. And this is the procedure which I did. And what I want to highlight in this case is the traction which existed temporal to the fovea, where the initial schisis had started with the hyaloid ILM complex causing that. So I use Professor Mortada's multiple layer, which he calls as the envelope technique, along with a much wider peel. So I fortify the already thinned out foveal area, do a wide peel. Here I first did the nasal, but the main point of traction was on the temporal side, which was even identifiable clinically. So we did a nice temporal peel. And put all the 4 flaps on the macula, and I widened the temporal peel even more. So this is still with the air gas mixture in, and post of 1 week, she showed excellent resolution already. You can see the ILM flaps in future follow-up, 618 unaided vision, because we had to combine it with a phacoemulsification. So I'll straight. So what is the essential difference when we compare a myopic foveoschisis to a X-linked juvenile foveoschisis? This is a comparison I like to use. You see here the ILM is not under traction, while here the ILM complex, because obviously of the growth of the eyeball, is under traction along with the posterior hyaloid and the skytic vitreous. So I like to group these patients into a simple or a compound where it extends through multiple layers, which I feel is one of the simplest combinations. Previously, in my earlier cases, I used to do before I came in contact with Professor Mortada, I used to do a white peel and just an ILM peel, but now I do a foveal sparing peel. This is a patient with the white peel. I just wanted to show the difference. Pre-op vision 2120. Sorry, it was counting finger, and post-op 2040. Sorry for this wrong that thing, because we had again combined it with phacoemulsification. So what is my take on this surgery? There is a variability of response to surgery. Combined surgery works better in my hands. I don't do a indentation base excision, but I do a wide vitrectomy because I've already removed the lens. History of recent progressive decrease in vision is a good prognostic marker for me in these cases. Peripheral retina checkup is very important at conclusion. In absence of macular hole, ILM peel can give results, and even in macular hole, it gives excellent results. And even if you have a myopic macular hole with detachment, the flap technique works good. For anterior segment surgeons, important to rule out MMT before taking up patients of disproportionate visual loss for cataract surgery in myopic eyes. So these are some other cases, pre-op and post-op, done all by the flap technique. You see? Thank you very much.
Thank you, sir. Dr. Ajay, do you want to make a comment? Because you were trying to say something, your mic got muted.
Yes, Ajay. Can't hear.
Yeah.
Vishal, can you hear?
No, sir. You can carry on. Sir.
Ajay is here.
Ajay, sir, your mic is muted. Yeah.
Ajay, mic is muted.
Mic is okay.
Okay.
I think.
Yes,
Yeah.
Ajay.
Here.
Yes.
Now it's on.
Okay. Yeah, just I wanted to ask Dr. Hassan and even Dr. Shobhit's opinion on it. Like, if we make two large flaps, ileum flaps, as Dr. Hassan showed in his first case, so sometimes it gets collected on the prefoveal area, center of the fovea, especially if we have used PFCL during making the flaps. It has happened to me few times. Since then, I remove the PFCL and trim it a little bit. Don't keep it that large. And both my patients, the visual acuity was little limited than compared to other patients. So, what's the observation of others? Especially, I want to ask this question to Dr. Hassan and Dr. Shobhit.
See, the peel is never done under PFCL unless the retina is detached. If we have a detachment along with a myopic macular hole, that's where we use PFCL during the peel. The peels are done without the PFCL in place. And because I'm not doing a very aggressive base excision and I'm combining with a phaco, so I'm able to do quite a lot of peripheral vitrectomy without that thing. But yes, if I was doing, when I'm doing a macular case with a detachment, I like to keep the PFCL. Professor Motada, over to you.
Yes, in myopic foveus cases, as you know, there is no detachment, but the retina may be elevated, and there is no need to use PFCL during the ILM peeling or making the flaps. But as Shobhit said, if the retina is detached, you may do it with or without PFCL. If it is safer to do it with PFCL, then go ahead and do it. But in my the drawback with the PFCL is that once the retina is attached in these highly myopic eyes, the contrast is less than because the underlying retina, the underlying choroid and RPE are atrophic, degenerated. So the contrast is less. Sometimes you need to augment the staining, as we said, but you can do this by injecting the dye under the PFCL. So you go with it, but it is easier to do it in the absence of PFCL. So I may start doing with a detached retina, doing the eye lamp peeling without PFCL. If it is difficult and the risk of tearing the retina is there, then I restain and then I inject PFCL in order to have.
My question was.
Sir, I think Dr. Ajay is trying to say that if because of sometimes overstuffing or large flaps, there is a hump in the center.
Like in your first case, I saw, because I usually trim that. I had also had a bad experience. Like the patient had a little poorer vision gain, possibly because of that material in front of foviola. So is it not good to trim it if it's the flaps are too large?
yes, you can in an eye in a foveal schisis you can trim it, and also in myopic macular hole you can trim it. Um, and the OCT picture will be much nicer with no this
No hum.
elevated hub.
Yeah.
Exactly. But believe me, it has nothing to do with the visual acuity, and
Actually.
it never induces pre-retinal fibrosis or pre-retinal membranes or epiretinal membranes. So maybe the OCT does not look nice, but you can avoid this by trimming the flaps, and then you can create the flap over the hole, or you leave it without creating flaps over the foveal schisis. In foveal schisis, the aim is not to peel over the fovea. This is the target, so as not to create a macular hole. But with in the presence of macular hole, you need the flaps to put them over the macular hole, not to close the hole, but to assist in closure of the hole. And the flaps are not inside the hole; they are over the hole. It is not inside the hole; it is just put over the hole.
So
It is not stuffed.
it
It's
is
just
not a
over there.
mechanical. It's not
It
a
is not
mechanical.
stuffed. No, it is not stuffed.
Yeah.
Never.
Professor Martara, I would like to have your opinion. Most of my cases, patients demand a phaco along with this macular surgery with even myopic eyes, even if they are a little young. And they then demand a surgery for the other eye, for the for the clear lens. Which, because of the disparity, I don't want to make them myopic in this eye. So I like to aim towards a myopia of about minus 1.5, which I keep them. So what is your opinion whether we should be combining a phacoemulsification despite clear view in this eye or not? Because many times I refuse them because I tell them that I'll have to unnecessarily do the other eye. I would like your opinion. Yes, if the patient is elderly, I go in for both.
If the patient is young and has a myopic macular hole with or without detachment, I try hard to preserve the lens so as not to do phaco. But
Good.
if there is cataract or you are obliged to do or you are forced to do combined phaco-vitrectomy. Post-operatively, you can correct the other eye with contact lens or something like that.
Yeah, that's the first option we give.
But yes, but I'm not with doing clear lens extraction on the other eye.
You see,
Because
I'm also not in favor. That's why I avoid it in young patients. But there have been instances when they have demanded it because they want to get rid of the refractive issue also.
Shobhit,
yes,
that's a heterogeneity because
if
you
the patient is
I know,
motivated,
I know, but that's why I put up this point. It's a practical issue.
yeah,
Young patients, because many of them have not come to you for the macular pathology, they have come to the hospital for a refractive procedure, and the macular pathology is discovered during their work.
Accidentally. Yeah.
yeah, you are right. But we start with the contact lens, and if the patient is motivated to have surgery on the other eye, I don't like to put fake IOL. I don't like these lenses. If the patient can wear a contact lens, and some of them can wear a contact lens.
Yes.
But if there is a contraindication or the cornea become irritated or vascularized, so you have to do clear lens extraction, put an IOL.
Sure.
Dr. Shobhit, may I ask a question?
Yes, Virendra.
Sure, sir.
Yes.
Refractive
Dr. Shobhit,
surgery.
your first case was having a vision difference of one eye 6.9, other eye 6.12. So, do you keep any vision difference of a particular level for foveal or the retinal surgery for myopic macular hole kind of thing? because only one line difference was there. Though it has progressed
No,
over
that
time.
was in the initial. Second visit was 6:36. So
Yeah, so
I corrected her, and now she's after my life for the surgery in the 6/9
second
eye.
eye. So
She's
I think
demanding
ICL
it.
is a better
I was
option as
trying to tell her to use the
ICL
contact
can be
lens,
done.
but she has already taken a date from this. She's even got her COVID test done.
Sir, any audience
I think
questions are
Dr.
there?
Mortal is
Yeah.
right for a refractive surgery, ICL or something can be
Dr.
done
R.K.
rather than
Sharma?
clear
Yeah,
lens.
I have advised her
There are few
ICL,
questions,
but
Vishal.
she says I don't
Yeah.
want to undergo 2 procedures in the lit.
Dr. R.K.
I
Sharma?
advise her ICL only
Yes, yes.
with my cornea colleague.
Yes, I have few questions.
Yes, sir.
If time permits and if you
Yeah,
permit,
please.
I
Yeah,
can
we
go
can
ahead.
have a quick questions from the audience also.
Yeah. So there is one question from Dr. Pawan Puneet Malhotra from Chandigarh. He says he wants to know what is the meaning of choroidal graft alignment. Dr. Shobhendu,
Yes.
what is the meaning of choroidal graft alignment?
Graft alignment, that means it should be centrally placed in the macular area.
No, I think he means whether it's upside down or, the other way around,
Or the reverse?
on the reverse.
You should always respect the upside down manner of the choroidal graft, and it should be aligned in such a way so that it can attain its position in the future fovea.
Okay.
Okay.
And
The central
there is
position of the
another question from Dr. Anand Pangarkar from Maharashtra. He wants to know from Dr. Hassan Murtada that what happens to the central ILM left in place in doing foveal sparing ILM peel. So what are the sequelae and what are the complications or side effects, whatever? Dr. Hassan, please.
Yeah, there is no complication from leaving these small flaps around the fovea. And after some time, you cannot detect them clinically. And usually I do not do OCT as long as the patient is not complaining and as long as the retina is stable. But clinically, you cannot detect them anymore. Maybe after a few months, you cannot see them on biomicroscopy. So I don't see any harm of leaving these ILM flaps around the fovea. And usually
But on OCT, they will be visible forever.
Yes,
Okay.
but this doesn't mean they are doing any harm to the fovea.
Okay.
On the contrary, you are protecting the fovea from the development of a macular hole if you peel the ILM across the fovea.
And second question to you, Dr. Hassan, is that how to manage cases with post-op graft shrinkage? And are there any chances of traumatic CNVM while maneuvering the graft?
How can you manage? Can you say the question again?
How to manage cases with post-op graft shrinkage, the shrinkage of the graft in the post-op period, and are there any chances of traumatic CNVM or the choroidal neovascular membrane developing with the manipulation?
I haven't seen. You mean retinal graft?
Yeah.
Retinal graft.
Yeah.
I haven't seen retinal graft shrinking. The aim is to close the macular hole. So, and also after some time, you cannot detect clinically the graft, but the hole is closed. And this is the target. So,
and the incidence of iatrogenic CNVM? No.
No.
Not seen.
Unless you iatrogenically injured the RPE and the underlying choroid. But if the operation went uneventfully, then there is no iatrogenic CMV.
Okay. Another question from Dr. Sonal Kalia to you is, if myopic foveoschisis cases, they have coexisting immature cataract, will you do a phaco along with the retinal surgery, or you do it before going ahead with
No,
the
I
myopia?
do it simultaneously at the same time. Combined phaco vitrectomy.
As Dr. Shobhit does.
And Shobhit also.
Yes.
We are also doing almost all our surgeries combined nowadays. Combined, at least macular surgeries.
Yeah, it should be done.
Even Vishal, even diabetic vitrectomy is
Even diabetic vitrectomies.
Absolutely. There's no need to
Yes,
separate.
Gas-induced cataract.
yes. In diabetic vitrectomy, because during surgery, if you left the lens in place, the back surface of the lens after sometimes becomes opacified with feathery opacification, and the visibility is hindered, and you cannot continue the surgery under good visualization, and you cannot remove the eye internal limiting membrane. So, and you cannot remove the vitreous base properly. So all these problems can be solved by combining vitrectomy with phaco and PCIOL. The problem of posterior synechia, lens deposits on the lens, I'm aware of all these complications. But if you weigh which is better, finally, you came to the conclusion that removing the lens at the time of surgery offers much, much better advantages or more advantages.
I agree with you.
And Professor Moncada, moreover, as compared to the time when in the early 90s when we were doing ECC-IOL combined with vitrectomy with these eyes and not using any anti-VGFs, and our laser pros were also not that good that they could reach the extreme periphery, there was more incidence of post-operative rubeosis. Nowadays, we hardly see it because we are lasering right with the curved probes up till the aura, just short of the aura, and we are giving pre-op anti-VGF and even giving post-operative if needed.
True.
May I add something regarding the rubeosis? So I think why we are not seeing more rubeosis, or we are seeing less rubeosis than in the past, because we are applying laser up to the aura. Exactly. In the past, because we were preserving the lens, laser was only applied to the equator or just to the pre-equatorial. But nowadays we do indentation, we apply laser to the retina over the aura. And if we review the old literature, the post-operative hemorrhage that was occurring at that time was due to new vessels developing from the peripheral retina, the peripheral ischemic retina. Nowadays, we do not see rubeosis, and we rarely see post-operative hemorrhage or late post-operative hemorrhage, because the periphery, the ischemic peripheral retina is already ablated and lasered. So these complications are now very, very rarely seen.
And basically the port, 20 gauge port, and the portion between the aura and 20 gauge port was also prone to port neovascularization as compared to these smaller gauge ports. What is your view on that?
I think with a small gauge vitrectomy system, also the instance of vascularization, the inner vascularization or vascularization of the sclerotomy from inside is much less than with the 20. And also with the use of the trocar system, because with the 20, by the end of the operation, you find your sclerotomy is not 20 gauge, it is larger than 20 gauge. But now we are using trocars that, and also the slanting or the direction of the wound is not perpendicular, it is beveled, and also this induces self-closure of the sclerotomy. We do not use sutures anymore in most of the cases, and so the development in the wound construction, wound closure, laser to the periphery of the retina, base vitrectomy, proper base vitrectomy, all these contributed to less instance of hemorrhage and rubeosis and what was described as retrolental fibrovascular proliferation.